I think a fundamental issue concerning integrated care is to look back actually at the past decade in health policy, when what's actually mattered most in practice to health managers and to clinical leaders has been sorting out what we call elective care. So reducing waiting lists and ensuring people that can get much quicker access to outpatient appointments, to hospital waiting lists, and indeed to see their GP, their family doctor. So what we now need is, in the way that was made to matter for managers and clinical leaders, and huge progress has been made in that area, we now need the same degree of urgency and importance to be attached to care for people with long-term conditions, frail older people, vulnerable children, and so forth. Because only if that really matters will this integrated care stand a chance of becoming a reality.
The final key issue, I think, which is really important, is we can't divorce ourselves from the economic realities in which the service now faces itself. But when you look at the long-term sustainability of the health and social care system, you would recognise that if you don't change that system to move care out of expensive hospital institutions or outside of expensive nursing home care and move it into the community and even into the home where care is, can be coordinated around patients' needs, then you're not going to end up with a system that is going to be financially viable in the long term. So as well as improving patient experiences of care and user experiences of care, this is a very important part of making the health system more sustainable in the longer term.
One of the particular organisational barriers we face here in the NHS in England is having quite a significant separation between primary care, so community-based services, and secondary care, that's hospital-based care. And furthermore, there's another division in terms of what we call social care, the services that people receive from local authorities in terms of social work and other home care. So we've got those sort of organisational divisions which can make it difficult for services to be properly coordinated for patients. But there are other barriers as well. There's another very practical one in terms of a lack of a shared patient record. So the ability for different professionals, whether that's social workers, nurses, GPs, to actually all have access to the same body of information about an individual. And one of the results of that is that patients and their carers end up telling the same story time and again to the professionals who are caring for them. And also, people might turn up at the hospital accident emergency unit, and that unit will have no knowledge about the fact that patient perhaps has diabetes or airways disease or other pre-existing problems. And then perhaps the third significant barrier is a broader one, but it's actually about the culture of the NHS and its management. And what we've been hearing in the work that we've done for this project is that culture all too often is rather rules-based and concerned with people seeking permission for what it is they want to do to try and sort out some of these knotty sort of care problems. And people saying to us that they want something that's, in a sense, more enabling and gives them the chance to perhaps take a few risks and to actually stretch the boundaries in terms of finding some quite different ways of providing care for this vulnerable and indeed quite complex group of patients and their carers.
And on the back of that, there are a range of policy barriers that actually cause, I think, a lot of this problem. One is related to the financial flows, how different organisations get incentivised to do their business in the system. So one particular thing that comes through very clearly are issues related to the tariff and the fact that it becomes quite problematic to be able to coordinate services jointly, particularly between primary care services and those services occurring in hospital settings, and indeed in difficulties in pooling budgets between health and social care in order to come up with some sort of collective response. So there's a need to be able to think of new ways of bundled payments, new ways of changing the nature of the tariff system so you can invest in different types of care than currently we have. I think a second barrier related to that is the issue related to governance, related to the regulatory regimes. And I think there is a case to be made for all of those at the highest level, from the Department of Health to the Care Quality Commission to the National Commissioning Board, to Public Health England to bring their ideas together into a single outcomes framework that can be shared collectively, or at least to align it very closely. And if they did that, that would be a very supportive, strong mechanism, I think, for driving through collective change locally on the ground. I think there are a couple of other areas where I think probably change need to happen, and one is related to the issue around the choice policy. And at the moment, a lot of commissioners will feel themselves in a compromised position because they need to offer choice of 4 or 5 different hospitals to individuals as part of that policy. But at the same time, they want to innovate. They want to create a new integrated package of care, potentially using a network of providers under one contract. And that becomes very problematic to do because it goes against potentially some of the aspects of that choice policy. And at its heart, integrated care is all about choice, but it's about a different type of choice. It's about choice of your care and treatment options in a shared decision-making structure with your professional in order to make those really good decisions. I suppose finally there are issues related to competition as well that run alongside that, and that leads to wider questions about what competition really means here. I mean, in the NHS we have potentially something like 150 different provider organisations, and yet we're fixated on this issue of competition. Whereas we have, for example, 6 supermarkets, and there is clearly a lot of competition that happens between them for consumers to buy their products, and a very strong competitive marketplace in which they do that. So there is something in enabling integrated care to happen and understanding how competition and integration are actually not diametrically opposed, that they can happen together under the same framework. Well, the first thing is policymakers really need to set down a clear narrative as to why integrated care is important and why it needs to be developed at scale and pace and why it needs to be done now. And that needs to be based on a recognition that care to many individuals is very poor, a recognition that too much of our resource is spent in acute hospital settings where it ought to be based in community settings and in the home environment, and that if we don't change the system in this way, it will never become a sustainable system within the current resources and the future resources that we have for it.
I think two of the perhaps most important recommendations we're making in this work are, first of all, about the vital need for sustained support for people seeking to develop integrated care locally. That will come both in the form of practical support in terms of using data, analysing population needs, but also project management, making change and so forth. But then broader support in terms of organisational development, linking up with other sites trying to do this work and sharing that learning more generally. And then finally, and very importantly, the need to put in place robust and long-term evaluation of all the different initiatives to try and develop integrated care, so that those fundamental baselines about the experience that patients and carers are having of current services can be used to really test out the extent to which this effort around integrated care is bearing fruit.